a great pleasure for me to be here in this streaming, in this presentation with very wanted colleagues. Samir, thank you for inviting me to this meeting. And it's my pleasure to see you, Bob, in another team. I went to Miami the last week because the Latin American Congress, but I can't see you because I stay 3 days only in Miami with many conferences. But I'm going to talk today about our work with intraoperative MRI in glioma surgery, because I think it is a good tool by the future in this kind of tumor where we need some help from the technologies and the computers to do the best for our patient. This is my clinic in Buenos Aires, Belgrano Adventist Clinic. You are invited to know when you want. Okay. And I ask myself, is it the real? Acá tengo. Está tapando la pantalla. Okay. Is it the real glioma treatment results? All of our patients with glioma will be dead before 10 years, or these results, these values are based on incomplete surgical resection? This is my question. I think there are a new philosophy in neuro-oncology was proposed for Professor Dufault, and it is early and complete resection, mainly considering the low-grade gliomas. And what the guidance says about this? All the guides recommended maximal safe resection feasible in low-grade gliomas and in high-grade gliomas. But when Professor Sawasha studied what was the total resection in this surgery, he saw that it has been limited to a mere 6.2 or 12% of the total of the resection. This means that 90% in glioma surgery were partial resection. Peter Black in Boston was the first neurosurgeon who operated glioma using intraoperative MRI in United States. The second country was Germany, the third Finland, Canada, and we were the 5th country in the world in use intraoperative MRI. We started on July 2000 with our first intraoperative MRI surgery for glioma. This was our old machine, Picker system, open magnet, 0.23 Tesla. Here you can see the operating room during a check-in a control. Here we are operating with the magnet side. Nowadays we have this system, and I think that the low field MRI, I think it is time to reconsider the low field MRI into the operating room for the future, because these systems are simple, practical, easy to use, very quickly to do MRI, neurosurgeon friendly, and the most important for me is that using low-field MRI, we can respect the condition of the conventional surgery. This is our system. Here is the patient in surgical position, and here we move the surgical tape to check the steps of our surgery. And we can move to surgical position, to checking, to surgical position, to check every time when you need to do it. This is the view from the operator room. And you can see this, the surgical position is the same that in conventional neurosurgery. And the MRI is like a C-arm for control or for check orthopedic surgery. It is a side, but it is ready for the time when the surgeon considers that it needs to check the step of the surgery. Here we are doing the craniotomy. And it is very easy to move the patient and to achieve an image. We cover the patient with the surgical field, and with this simple movement, we put the patient in condition to achieve an image, MRI image. We use surface coil, very easy to connect, to put, and we see the image and going on with the surgery. Here you can see we are operating, removing the glioma, and we put a mark at the bottom of the cavity, and in only 3.57 minutes, we can get 3.57 minutes. We can get intraoperative image and remove this small tumor here. This is the postoperative CT scan because I don't have MRI, postoperative MRI, because this case was operated the last week. But I'm going to show you some surgical cases. For example, this glioma, high-grade glioma in this location, left hemisphere, left side. Here we are preparing the patient. This is the operating room. This is from the operator room. We study the anatomy, of course. We choose the approach, avoiding the eloquent areas. And after that, we going to the operating room. We can fuse the image with the MRI that we get at this moment, program the navigator, and we can hear the tumor before the surgery, and here we are going to the tumor, it is here, and after removing it, and here the same, we are going to the tumor here, we check that we are in the correct direction, and after removing, and the same, the tumor before and after. And this is high-grade postoperative MRI with complete resection, the patient before and after removing his tumor. This is another case with a high-grade glioma, frontal lobe, right frontal lobe, 82 years old man. And here you can see all of these are intraoperative MRI. Here we attack the tumor and we can see a remnant at this position here in sagittal slice, and after total removing it. the same in coronal sequence, before the attack the tumor, partial resection at the middle of the operation, and after complete resection, and the same in axial sequencing. And this is the patient, 26 months after that surgery, complete recovery, of course, with radiotherapy, chemotherapy, but he is without tumor. If we have this kind of control of our work, we can operate these tumors. We can operate these tumors too. In the last 10 years, gliomas of corpus callosum have been operated with very good results in many cases. You can see here, these are intraoperative MRI with the grade of resection of the tumor and the patient immediately in the postoperative. In low-grade gliomas, it is very important because these tumors, it is impossible to see, to differentiate of the normal brain. And this is the brain surface, and after removing this tumor here, and this is the MRI several times after removing the patient. Here, removing it, here you can see 13 years tumor-free after the resection. This girl was a young girl here, and he is a mother with her family and her children. This is the intraoperative MRI during the surgery. We can check the exactly localization of the tumor, and this is the result. In insular tumors and in children, even in children, it is a very, very important tool to have the MRI, because it's not easy to be sure of the limits, mainly after we are working inside the tumor. Here you can see the baby. This is the surgical field, the first control with this remnant of tumor on flare. And here the patient a few days after surgery, and this is the last MRI that we get with complete resection of the tumor, and this is the patient several years after surgery with no tumor and without neurological dysfunction or sequela. This is an insular tumor. In another case, we have more than 70 cases of insular tumor operated with intraoperative MRI. We can use different tools for this, but this is the surgical view. This is the localization of the tumor. Here you can see the tumor, and this is that I can choose complete resection of this lesion. This is the surgical button, and this is the patient a few days and several months after surgery, and this is her MRI. We can use every tools to complement the image, the intraoperative image. In this case, look, this tumor was located very close to language area and motor area. This is the tractography. You can see the tumor here. We decided to use electrocortical stimulation to localize the central sulcus here and to localize definitely the tumor. This is the MRI, and this is the localization of the lesion. We check with a mark on the brain surface to be completely sure that the tumor is under this area to prevent neurological damage. And here you can see this is intraoperative MRI. The bone is open here, and this is the image with complete resection of our lesion. Here you can see this was the area after removing the tumor. This is the area of the tumor, and this is the patient with no, excuse me, with no neurological deficit. This is several years ago. We presented in this case in the World Congress in 2013. Another diffuse glioma, low-grade glioma, we studied before with high MRI, before the surgery. We decided the approach using tractography, spectroscopy, ever that we can get from a high-field MRI. But in this case, we use también evoked potential, cortical stimulation. You can use every other tools for remove the tumor in safe manner. Here we are using subcortical stimulation for detecting the spinal tract. This is the surgical field after removing the tumor, and this is the GER. Another localization, anatomical resection, and this is the postoperative MRI, the patient without neurological dysfunction. We can get intraoperative MRI even to operate awake patient. We can operate patient awake with low field MRI. It is very difficult with high field MRI, but it is easy with low field MRI with this design. The tumor was located in this area, and we removed completely this. This is the MRI, 28 months after surgery. This is the brainstem after removing the temporal lobe. Another case, this area here, we thought that it was a cortical dysplasia, but it was a low-grade glioma. We removed.
4, 5, 6, 7.
You can operate with the patient awake without any difficulty, and this is the resection of the tumor. This is very rare case because this patient had two tumors, one in right temporal lobe and the other in parietal, left parietal lobe. We decided to operate first the temporal lobe. It was an oligodendroglioma. We removed completely this tumor, and several months later, 2 months later, we operated his parietal tumor, using intraoperative MRI and electrocortical stimulation to localize motor area here.
Dale, estoy filmando, Roberto.
Antes. Donde filmaste antes, ahí.
You can see the cortical stimulation. This was the tumor. And after removing it, this is MRI 7 years postoperative, 10 years postoperative with his beautiful family. Here, 14 years postoperative, no more tumor on the left and on the right, and no more tumor. We used to, in this huge tumor, really very difficult. Some neurosurgeon perhaps could have doubts about if operate or not operate this case, but we decided to operate it. Here you can see after removing the tumor. And this is the surgical field after moving. And this is the patient right after the operation, in the immediately post-operative, 6 months later. You can see, I think 3 years after surgery, his MRI complete with no remnant, no residual tumor. And she is the patient. This picture was taken 3 years after surgery. It was an anaplastic oligodendrocytoma, and of course, she received radiotherapy and chemotherapy. We can use two neuronavigation, and we can recalculate the navigator with new image that we get during the surgery, and it is very useful for these tumors in the midline. Here you can see the tumor. This is the location of the tumor. Intraoperative MRI using Navigator 2, Neuronavigator. And this MRI after resection, the patient a few days in the postoperative. And for the last case, and I want to share with you, is this patient is a girl, a baby, 2 years old, with this tumor, that she was operated in another apartment for a great neurosurgeon using neuronavigation. But 6 months later, she came to my office with this tumor remnant here, with an area of resection here, but with very difficult tumor in central area. This is the tumor. It was an oligodendroglioma. We decided to remove it, to give a chance to remove it. We operate, and here you can see the patient 10 days postoperative, 1 month in winter holiday with her family. This is the patient starting kindergarten here, with a light right hemiparesia, but normal life. This is the MRI, 7 years postoperative, and this MRI is 2017, several years after surgery. Nowadays, she is a 14-year-old girl, plenty of health, and without tumor here. And this is that I say like a new paradigm in neurosurgery. It is necessary to remove completely low-grade gliomas, of course, because this is the result on the right, on the left, pardon, with complete resection of the low-grade glioma. And this is the result after partial resection. It's completely different. That's why I think that it is possible that this is not the final evolution of all of our gliomas. I think we can change the survival in low-grade glioma, the survival opportunity and cure opportunity in low-grade gliomas. And it is necessary that neurosurgeons go on through complete resection in these tumors. Our results, we have gross total resection in 81.7% of the cases, and subtotal resection in 11. But if we consider only the patient that we operated on the first time with one surgery with intraoperative MRI, our results will be better because when we operate patient in reoperation after 2-3 operation, it is more complicated to remove it completely because it are more biggest, the gliosis is different to differentiate of the normal brain, but in the case in which we operate with the how the first option of treatment with intraoperative MRI, we can get gross total resection over than 90% of the cases. And if we make a subtotal resection in 10 years' time, we will be losing nearly 50% of our operated patients. And I think it is very, very important for the final evolution in young patients with low-grade gliomas. This is our statistic, and here you can see something very important. None of the patients with non-complete resection had a life expectancy of 10 years. Only had a life expectancy at 10 years and over 10 years, the patients in which we achieve complete resection or gross total resection of their tumors. I think that in the future, probably the low-field MRI could be like a C-arm for orthopedic surgery, our C-arm for check the neurosurgery. If we remove completely and this herniation, of if we put a screw in correct position, or if we remove completely a brain tumor mainly in glioma surgery. Okay. Thank you very much, and now we go on with the comments or a question, and later we go on with the World Cup football.
Thanks a lot, Roberto, for the excellent presentation.
Dr. Sameh, can I make a comment?
Okay, come on. Okay,
Roberto, that was a wonderful lecture from you, Roberto, and I enjoyed it very much. You see, low-grade gliomas were defined as diffuse, infiltrative. They are widespread, they are big. So the only treatment was biopsy and then consider radiation, and those kind of things were there. And now there is no question that radical resection is the answer to these tumors. And what you have shown is radical resection and complete resection, and that is a wonderful way of dealing with these tumors. Unfortunately, I didn't see your surgical technique as to how you remove these tumors. I'm not sure if you have seen my article on the technique of en masse tumor resection, where we have said that gliomas arise from a white fiber tract. They grow by expansion like a meningioma, and they displace the adjoining tracts. They affect the adjoining tract by virtue of pressure and deformation, and not by destruction. And you can develop a well-defined plane of dissection between the tumor and the adjoining brain. So this strategy of en masse resection on the basis of origin of tumor from a fiber tract and the pattern of its extension makes radical tumor resection a big possibility. So my strategy is to define a plane of dissection around the tumor and to remove it en masse. So what is your thought on this, Roberto?
I think we have operated more than 500 gliomas using intraoperative MRI. All neurosurgeons at the beginning of the use of this technology recommended to remove the tumor on FLAIR or in T2. But all of our cases, the results that you can see were achieved removing the tumor on T1, because we consider that the really tumor is T1. You can have infiltrating cells infiltrating the peritumoral area, but after you remove the tumor in T1, you can choose if you are going to remove 1 centimeter, 10 millimeters through the area, peritumoral area, when you don't have eloquent areas. I think this is the secret of our result. We remove the tumor in T1 and respect the fibers and the tracts. We observed that the tumor has not functioned. Using awake surgery from 2005, using electrocardiac stimulation, we ever detected function into the tumor. This give us the security of remove the tissue that in the MRI we detected as tumor. If the patient had previous neurological dysfunction, motor or language area, is because the tumor is infiltrating this eloquent area. But if the patient don't have lesion, when we are going to operate, the probability to we can remove the tumor and the patient recover complete function without sequela is very, very high. If the eloquent area is infiltrated, the patient came to me with neurological dysfunction, and this is because the area is affected by the tumor, and it's impossible to remove the tumor without affect the neurological function. But we recommended, if you have that, for example, when we operate with neurophysiologists into the operating room, and in our first experiences, I saw the intraoperative MRI, and I talked with the neurophysiologist, and I say them, this area is tumor, and I want to remove it. But they say to me, no, this area it has function, neurological function, but it is tumor. But it is tissue with function. At the beginning, we left the tumor, but in a few months, the tumor, this area grow with a new tumor, a big tumor, sometimes turn to anaplastic glioma, and the patients lost the only chance, the only opportunity to be cured, that was that first surgery. After that experience, we decided to remove all of I saw in intraoperative MRI that it is tumor, and of course, when I'm sure that it is tumor, I remove it. I thought it before with the family and with the patient, because the low-grade glioma is not a benign tumor. They are tumor with potentially malignant potentiality, and I decide to remove it when I'm sure that it is tumor. It's different in another tumors. In meningioma, you can see displaced the tract, but no infiltrated, of course, as you say, Professor.
Thanks a lot, for excellent presentation.